नमस्कार, आप देख रहे हैं न्यूज़ हाट। मैं हूं आपके साथ अस्मी सराफ। इस वक्त हम मौजूद हैं होटल चाणक्य में और आपको बता दें कि आज हम लोग यहां इसलिए मौजूद हैं क्योंकि यहां हमारे साथ अभी कुछ देर में कई सारे डॉक्टर्स होंगे। डॉक्टर्स यानी कि यहां आज स्पेशली ऑन्कोलॉजिस्ट को बुलाया गया है। ऑन्कोलॉजिस्ट वो डॉक्टर होते हैं जो कि कैंसर मरीजों को देखते हैं, कैंसर का इलाज करते हैं। देखिए, कैंसर सिर्फ एक बीमारी नहीं है, यह इंसान की ज़िंदगी, उसके सपनों और पूरे परिवार की हिम्मत की परीक्षा लेता है। जब कोई अपने ही घर में इस दर्द से जूझता है तो टूटता सिर्फ मरीज नहीं, उसके साथ माँ बाप की उम्मीदें, जीवन साथी की मुस्कान और बच्चों का बचपन भी धीरे धीरे सहम जाता है। इलाज की तकलीफ, अनिश्चित भविष्य और हर दिन की चिंता पूरे परिवार को अंदर से थका देती है। फिर भी सब लोग मुस्कान ओढ़कर एक दूसरे का सहारा बनते हैं। इस लड़ाई में आंसू छुपाए जाते हैं, दर्द बांटा जाता है और उम्मीद को आखिरी सांस तक जिंदा रखा जाता है। देखिए, औरतों में सबसे ज़्यादा कॉमन है ब्रेस्ट कैंसर, यानी कि छाती में जो उनको कैंसर हो जाता है, जब एक गिल्टी कैंसर का रूप ले लेता है, और बचदानी की कैंसर यानी कि गायनेकोलॉजिक कैंसर। तो आज जितने भी डॉक्टर हमारे साथ मौजूद हैं वो हमें गायनेकोलॉजिक कैंसर के बारे में अवेयर करेंगे, उसके बारे में बताएंगे और ये भी बताएंगे कि किस तरीके से हम सुरक्षित रह सकते हैं, अपने आप को सेफ रख सकते हैं ऐसे खतरनाक बीमारी से। तो चलिए अंदर हम चलते हैं और डॉक्टर को सुनेंगे, उनसे बातें भी करेंगे। तो इस महत्वपूर्ण इवेंट का हिस्सा आप भी हमारे साथ बनिए।
Are more likely to present at advanced stage, have bilateral disease, have gross residual disease after surgery, area of microinvasion is seen, and invasive implants are associated with these tumors. So this is one of the poor prognostic factors in borderline ovarian tumor. Then talking about the implants, borderline ovarian tumor with peritoneal implant. So the term implant is used in the context of extra ovarian spread of serous borderline tumors. It is present in around 15 to 30% of the cases. By definition, these are non-invasive implants, and any invasive implant is classified as low-grade serous ovarian cancer. So this occurs because of detachment of the cells from the tumor surface, and these cells get attached to the serosa or omentum where it starts growing, but it do not invade the peritoneum. Implant, the term peritoneal implant is not used for mucinous borderline tumor because whenever there is extra ovarian disease in mucinous tumors, this is considered as metastatic disease from a undiagnosed carcinoma or a mucinous carcinoma, non-ovarian mucinous carcinoma like GI primary or other primaries. Role of immunohistochemistry, there is no role of IHC marker in differentiating ovarian cancer from borderline ovarian tumors, but for differentiating different histological subtypes of borderline tumor, we can use immunohistochemical markers, and IHC is specifically used for mucinous tumors because there could be possibility of non-ovarian primary for which IHC may be useful. Regarding the pathogenesis, mutation in KRAS and BRAF are the early genetic events which are responsible for borderline ovarian tumor. It leads to activation of MAP kinase pathway, which leads to uncontrolled cell proliferation. Clinical features, most of the times, around in 30% of the patients, borderline tumors could be incidental finding, and in other cases, in 2/3 of the cases, borderline tumors present with very non-specific symptoms like in other patients with ovarian cancer. Tumor markers are not very useful for diagnosing borderline tumors. It can be raised in around 40% of the stage 1 borderline ovarian tumors. CA125 can be raised in 40% of them, and in stage 4 borderline tumors, around 80% of the time CA125 is raised. CA19-9 can be raised in mucinous borderline tumors. None of the radiological investigations can accurately diagnose borderline tumors. The ultrasound findings which could be suggestive of borderline tumor are the papillary projections or the multiple locules, just like other complex ovarian cyst. And there are no ultrasound feature which is pathognomic of borderline ovarian tumors. Iota adnex model along with CA125 can help in differentiating benign tumors from borderline tumors and early and advanced stage ovarian malignancy or the secondary tumors, and the accuracy, the sensitivity is around 93 to 96%, and the specificity is around 60 50 to 75% for diagnosis of borderline tumors in complex adnexal masses. Coming to the management part, the mainstay of treatment for borderline ovarian cancers is surgical treatment, and comprehensive surgical treatment includes removal of all the macroscopic disease and complete peritoneal staging. The extent of surgery depends upon the age of the patient, the desire for fertility preservation, stage at diagnosis, and presence of implants at the time of diagnosis. And full surgical staging is recommended for all the patients who are being treated for complex adnexal mass, because there is always a possibility of having borderline ovarian tumor, and borderline tumors can be diagnosed only on histopathology. So complete peritoneal staging has to be done for any complex adnexal masses if we are operating on them. Radical surgery can be done should be done for women who do not desire fertility.
We know that if it recurs, it metastasizes, the survival goes very down. So multidisciplinary approach we use when we see a triple negative breast cancer, including medical, oncologists, breast surgeons, radiation oncologists, breast radiologists, pathologists. So basically neoadjuvant therapy comprises of chemo and immunotherapy. Then it will be surgery, and adjuvant therapy will be chemo, radio, immunotherapy, and now PARP inhibitors have come into picture. So conventional neoadjuvant chemotherapy composed of adjuvant chemotherapy results in a PAT CR of only 35 to 45%, and when immunotherapy Keytruda was added, the PAT CR became 64%. So as we know, PAT CR does show a survival correlation. So improving PAT CR was the main thing which got incorporated because of the incorporation of immunotherapy in neoadjuvant setting. So what are the principles of preoperative systemic therapy? So known benefits are facilitates breast conservation, can allows time for genetic testing, planned breast reconstruction. So treatment responses provide important prognostic information at an individual level, particularly with triple negative or HER2. So we can look for PAT CR which correlates with overall survival. Identify patient with residual disease as higher risk of relapse to allow for the additional supplement adjuvant regimens, particularly in TNBC, like we add capecitabine, or HER2 positive breast cancer we add TDM1. So the pre-operative or adjuvant systemic therapy for triple negative breast cancer is dose dense. Dose dense chemotherapy was already there. What was changed is we have now added pembrolizumab. So high risk triple negative breast cancer, pre-operative pembrolizumab plus carboplatin plus paclitaxel, followed by preoperative pembrolizumab plus cyclophosphamide plus doxorubicin, followed by adjuvant pembrolizumab. So this has become the standard of care in nowadays. So results from Keynote 522 demonstrated a statistically significant improvement in event-free survival in pembrolizumab combination arm compared to chemotherapy group, and the hazard was quite impressive. It was 0.63, so there was almost 37% reduction. In United Kingdom, a national prospective study showed that many centers opted for mastectomy over NST in almost 30% of patients with large tumor to breast size ratio, missing the potential opportunities for surgical downstaging. So neoadjuvant systemic therapy improves surgical outcomes. If you give neoadjuvant systemic therapy, it downstages the tumors, allows for breast conservation surgery, potentially opportunities for response prediction, serve as a platform for early assessment of novel agents, potentially reduces the extent of axillary surgeries and reduces morbidity associated with the axillary lymph node dissection. So patient with early TNBC, administration of this therapy in neoadjuvant setting, the combination of Keytruda with chemotherapy represents the new standard for most patients. So rationalizing what the need of immunotherapy, we have seen that one of the category of triple negative breast cancer, it's the most immunogenic breast cancer subtype with a higher PD-L1 expression level and more tumor infiltrating lymphocytes. So blockade of PD-1, PD-L1 axis has emerged as therapeutic target to enhance anti-tumor immunity. In Keynote 522, the addition of pembro to platinum containing NSCT results in significant increase in percentage of patients who had a pathological complete response. We have seen almost 65%. Addition of pembro before and after surgery for total duration of approximately 1 year led to lower risk of distant recurrence. So indication for pembrolizumab in early TNBC. So Keytruda in combination with chemotherapy and neoadjuvant treatment, and then continues as monotherapy as adjuvant treatment after surgery, is indicated for treatment of adults with locally advanced or early stage triple negative breast cancer at a high risk of recurrence. So this was the trial which evaluated the combination Keynote 522. So this was basically two groups with In one group, Keytruda was there 200 milligram Q3 weekly, along with chemotherapy, paclitaxel carboplatin, and one was placebo with paclicarbo, and then Keytruda with epirubicin or doxorubicin with cyclophosphamide, followed by surgery, followed by adjuvant Keytruda or placebo. Main efficacy outcomes were PATH-CR rates, event-free survival, and additional efficacy outcome was overall survival. The key inclusion criteria was size should be more than 1 centimeter but less than 2 centimeter. Involvement, nodal involvement, enrolled regardless of tumor PD-L1 expression. So PD-L1 expression was not taken into account while doing this. And exclusion criteria was obviously autoimmune diseases or medical condition that requires immunosuppression, because we are going to use immunotherapy. Stratification factor was a nodal stated tumor size and choice of carboplatin. So this was neoadjuvant cycle 1 to 4 Keytruda plus paclitaxel 80 mg per meter square either weekly or with carboplatin AUC 1.5 Q weekly, and then cycle 5 to 8 it was Keytruda, doxorubicin, cyclophosphamide, and then adjuvant Keytruda following surgery, almost 9 cycles. So 8 cycles before and 9 cycles of Keytruda after surgery. Median age was almost 49, which corresponds to our practical hope. Mostly were females. ECOG performance status was good. Pre-menopausal almost for 56%, post-menopausal 44%, and T2 were most common 68%, T3 19%. Nodal involvement was there in almost 60% patients. Overall disease stage 2 was 75%, stage 3 was 25%. So a meta-analysis of 52 studies published, it has shown that the analysis revealed the patient who had PATH-CR as compared to absence of PATH-CR is significantly. So PATH-CR basically correlates with overall survival. So in this trial, in TNBC patient, 5-year EFS in patient with PATH-CR, almost survival is 90%. And patient who has not achieved PATH-CR, the survival goes to 57%. So this is the correlation between PATH-CR and survival. So PATH-CR becomes an endpoint for triple-negative breast cancer. So if you see the event-free survival and overall survival, the hazard ratio is quite impressive if your patient has achieved PATH-CR or no PATH-CR. So
they want us to do something for them. And very often patients are well preserved. Means we think that advanced malignancy or recurrent cases, they all have to be very, very catastrophic and moribund. That is not always the case. Very often patients with recurrence or metastatic disease are fairly well preserved, and we can offer diversion procedures. However, they are not interested. Most patients say if it's not curative, if it is only a diversion, then we might not be interested. Because you have to live with a urobag, you have to live with a stoma bags, or you have to have a stoma, you have to have a urobag, which might not be very acceptable, and we have to respect their decision because it's not a very easy decision to make. Now, the difference between diversion procedure for a rectovaginal fistula and a vesicovaginal fistula is that in cases of rectovaginal fistula, the diversion procedure is relatively easier. You just have to transect the rectosigmoid above the level of where the fistula is formed and bring it out as a colostomy. Whereas in case of vesicovaginal fistula, we are creating a conduit using a segment of the bowel. And intestines are essentially an organ meant for absorption. They will continue to absorb waste products of metabolism, that is urine, and this in the long term will have problems. It's not, we are actually altering the natural pathway, the genitourinary pathway and the GI pathway of the patient. So this has its own problems, which I will be covering in due course of my talk. And obviously you have to create a conduit. Now there are two types. Now you can have a continent and an incontinent procedure. Incontinent procedure, now when we create a, first let me talk of the incontinent procedure where we take a segment of bowel and create a diversion. Now urine is collecting into the conduit and slowly trickling out, collecting in the, coming out to the stoma. So the patient has to empty her bag time to time, and this can have its problems. And obviously she is not able to perceive bladder fullness. Whereas in case of continent type of procedure, we are actually taking a segment of intestine, that is the cecum and ascending colon, and making a pouch. And the ureters are implanted into this pouch, and the terminal ileum is fashioned into a something like a sphincter that and brought out as a stoma. So once the patient perceives the fullness, or she empties the urine with clean intermittent self-catheterization. So it's not a case where urine is continuously spilling out and collecting into a bag. Whereas in a continent type of procedure, as I said, it's frequent emptying of bag, and in both cases, whether we do a continent type of procedure or incontinent type of procedure, the problem is that the bladder with the fistulous opening is still left behind, and that is exposed to ascending infections, this recurrent infections, and this is another problem which patient will face. It's not that only some patients face. Every patient will face, and recurrent UTI, frequent use of antibiotics becomes necessary. Now, in most of our patients, we are performing mainly two types of procedures. Then we come to the more commonly performed, that is the Bricker type of ileal conduit. In this procedure, what we do is, we take a segment of ileum about 25 centimeters long, about 15 centimeters from the ileocecal junction, and we fashion a conduit. Obviously, in this picture, as you can see, we have, with following trans-illumination, we have made windows in the mesentery, and this segment is now going to be fashioned into a conduit. Then, the ileal conduit has been done. The cranial end of conduit is closed watertight, whereas the caudal end of the conduit will be brought out as a stoma, and the ileal continuity is restored. Here it is an end-to-end anastomosis. Now, the ureters have been dissected up as low as possible, sometimes below the level of uterine arteries. As you can see, the left ureter, both the ureters have been held by a mixture or a right-angled forceps. The left ureter is dilated. So this is a case where you have carcinoma cervix, there is a vesicovaginal fistula, and there is a left-sided hydroureter. The ureters have been transected. Now, a very important step, that is spatulation. That is about half to 1 centimeter of the ureter along its length is cut, and they are implanted on the antimesenteric side of the conduit. Here, the left ureter is being brought out through the mesosigmoid, and the right ureter, you don't have the problem because the conduit, the stoma, is going to be on the right side of the patient. Then we put infant feeding tubes in both the ureters and bring it out through the stoma, and we fix it, and finally the caudal end of the conduit is brought out as a stoma, and we remove the infant feeding tubes about 15 days later. Well, the problem we face is maybe for the first 24 hours the urine output is low, despite there not being any problem. Sometimes the infant feeding tube, because ureters are always having this peristalsis, they try to push out a plastic tube that has been inserted. But then most patients continue to have clear urine after about 24 hours. So this is the brief description of the Bricker ileal conduit. And this obviously is an incontinent. Very often what happens is that patients have undergone inadvertent hysterectomy, or the ileal segment is full of adhesions. And how do we create an ileal conduit? So in such cases, we can offer a different kind of a procedure known as double barrel wet colostomy. And of course, this can also be offered to patients who also have a rectovaginal and a vesicovaginal fistula. So in this picture, you can see that the rectovaginal fistula has been identified and closed. The bowel segment has been separated from the specimen, the uterus vagina, closed, and then this rectosigmoid is transected at a healthy point well above the fistula, and the ends are closed, watertight. And then again, following the same procedure, ureters are mobilized as low as possible, and as you can see in the forceps, the tissue holding forceps, that's the ureter being implanted into the closed end of the sigmoid. And then a loop of colon is brought out as a loop colostomy. So the upper end is going to, you will have the stool coming out of it, and through the lower end, which has the infant feeding tube, you will have urine draining out. So if a patient has rectovaginal and vesicovaginal fistula, instead of making a diversion colostomy on the left side and Bricker type IL conduit on the right side, you can bring out both through the same stoma. So this is how it looks. As you can see on the lower opening, urine is draining through the infant feeding tubes, and the upper opening is for the stool. Now, coming to problems, as we all know, any stoma, you have problems with stoma care. So that I need not go in detail. Sometimes it's very difficult to make patients understand that you have to do the stoma care, or making the caregiver understand. Doctors will look after you for maybe 10 days or 15 days as long as you're in the ward. But after that, you have to go clean the stoma with soda bicarb, avoid a mucus plug formation. Whenever you see nothing is coming out of it, come and contact us immediately. I already spoke of infection, that is, the fistulus, the bladder with the fistulus opening is still there unless an exentration has been done, and that becomes a nidus for infection.
We corrected whatever you have done, the methods, explored the methods, and after that we should start this concomitant CT RT, because this is a radical treatment and this is a curable stage, not untreatable. This is a treatable stage.
So the best results we get when it is due to advanced nature of the disease. Those patients who present following radiation, following chemotherapy, they have the worst outcomes. The patient who presented following radiation, she died with
हम